Assalamu alaikum wa rahmatullahi wa barakatuh. Good day to everyone. Our third station today is systemic lupus erythematosus. Although it is a very not uncommon disease, but it is a serious disease. As you can see in these slides, that it can affect outside the body or inside. Every organ system, every area in the body can be affected. Up to the patient may have depression or insomnia, or the patient has arthritis with skin manifestation, or vasculitis. So SLE or systemic lupus erythematosus should be part of any diagnosis or differential diagnosis, especially in the era of COVID-19. We don't like to wait to diagnose SLE with all the criteria. Why? Again, this is typical patient with SLE. Our aim, our mission is to diagnose a patient as early as we can, because time means that we'll miss nephrons in the kidney or part of the brain or daily life quality of the patient. And this is all the criteria of 1997, and we can diagnose if the patient has 4 out of 11 criteria. But again, this is a typical patient. We have something new. This new criteria is developed collaboration between the American College of Rheumatology and EULAR, which is European Alliance of Rheumatology Association, developed in 2019. I make it easy for myself. I call it 10 criteria. It's 10 domains, and to diagnose a patient, you have to have a score of 10. The first 10 domains, as you can see, that it is constitutional, hematological, neuropsychiatric manifestation, musculoskeletal manifestation, mucocutaneous manifestation, cirrhosis manifestation, pleurisy, pericarditis, peritonitis, renal manifestation. What about lab? Three major again. APL, which is antiphospholipid antibodies, complement protein for the first time in the history of SLE, and the SLE specific autoantibodies. Shall we diagnose this patient? What about ANA? The most important entry criteria for diagnosis is the patient must have positive ANA at the titer of 1, 2, and 80, which is, we call it entry criteria with 10 domains. What about the scores? You can see in this different score, but the most important for me, that if the patient has positive ANA and the histological feature of lupus nephritis, this is a typical, or we can diagnose the patient or labeling the diagnosis of SLE. With combination of lab and different clinical manifestation, we can diagnose the patient as early as we can. How we can apply this in daily clinical practice? We have one case of one patient, a 44 years old woman with 10 years history of mild SLE. She attended the clinic complaining of fatigue and arthralgia. ANA is positive, 1 to 160, speckled pattern by immunofluorescence. She has recurrent oral ulcer, Raynaud's phenomena, headaches, one episode of idiopathic pericarditis, a small pericardial effusion on echo several years ago. Her lab manifestations show lowest leukopenia, normal hemoglobin, normal platelet, normal kidney function. And anti-Rho, anti-double-strand DNA are positive, and C4 has been low in the past, and Smith is negative. Very important, this criteria, that all should not be on the same time. We considering the latest and the past manifestation if it is confirmed by physician or lab on X-ray. If we're applying the new criteria, ACR EULAR 2019, we can catch diagnosis of SLE. Why? Because of positive DNA, positive DNA, C4, complement 4 is low, leukopenia, the patient has pericarditis and ulnar ulcer. Dear colleagues, we should use the new criteria of ACR, EULAR criteria for SLE to diagnose the patient as early as we can. Not like rheumatoid arthritis to save joint, not like gout arthritis to save the quality of the life with severe manifestation, but here it is a serious disease. We have to save the life of the patient and use this criteria in daily clinical practice. Thank you for your time and attention. Let us move forward to apply all these three criteria in daily clinical practice. Goodbye.